Traumatic cerebral aneurysms secondary to penetrating intracranial injuries. Definition: traumatic intracranial aneurysms may be the result of either penetrating or non-penetrating trauma. Period. Traumatic aneurysms were first described in 1895 by Guibert. Traumatic aneurysms are rare and represent less than 1% of all intracranial aneurysms, thought to be more common in the pediatric population. As a percent of intracranial aneurysms, period, they've been reported as high as 26 to 33% prevalence, period. Mechanism of formation depends on the mechanism of injury, period. More likely a result of penetrating versus closed head injury. Low velocity injuries include screwdrivers, knives, shotgun pellets, where traumatic aneurysms have been reported as high as 10 to 15%. And high velocity injuries usually due to bullets or shrapnel. In addition, skull fractures are common in terms of occurrence of traumatic aneurysms, reported as high as 0.4% in the pediatric population. Regarding formation of aneurysms, usually involves the disruption of vessel wall with varying amounts of the intima, media, and adventitia. Formation depends on the degree of involvement of the different internal structures of the false aneurysm, true aneurysm, dissection, or fistula, which may occur. Traumatic aneurysms are defined as true or false on the basis of the histological findings. True aneurysms demonstrate outpouching of the intima through the media along with fragmentation of the internal elastic membrane. Aneurysm wall consists of the intima separated from the adventitia by fibrous tissue. Slides showing traumatic aneurysm in A. This is an excised aneurysm showing extension into the dura below a skull fracture. In B, there is staining of the internal elastic lamina on the left with loss of smooth muscle, thickened tunica adventitia, and thrombus. In panel C, this is a higher power view showing the loss of the internal elastic lamina architecture and changes in the media and adventitia. True aneurysms account for the majority of saccular aneurysms associated with aneurysmal subarachnoid hemorrhage and are less common after trauma. False aneurysms constitute the majority of traumatic intracranial aneurysms, where there is contained hematomas with disruption of all three layers of the vessel wall. The distinction between true aneurysms and false aneurysms requires histological analysis, and it is not always possible to distinguish these on angiography. Majority of traumatic aneurysms occur in the supraclinoid segment of the carotid artery and along the anterior cerebral artery and branches. The anterior circulation is most often affected, occurring in the pericallosal vessels as well as the peripheral branches of the middle cerebral artery. Velocity of the projectile is usually correlated inversely with aneurysm formation. With lower velocity projectiles more common to be cause of aneurysm formation. Thus, shrapnel injuries are significantly more common cause of traumatic aneurysms than with bullet injuries. Shotgun and low caliber penetrating wounds associated with higher incidence of traumatic injuries, whereas high velocity bullets have higher kinetic injury and are more likely to rupture a vessel than damage the vessel wall. In skull fractures, vessel injury is thought to be caused by transient herniation of the cortex and vessel through the fracture site. Vessel fistulas caused by abnormal connection between the artery and venous circulation usually occur in the cavernous sinus and skull base. Dissecting aneurysms are less common after penetrating or non-penetrating trauma. Dissecting aneurysms usually occur in the skull base and involve the internal carotid artery and vertebrobasilar system. Dissections are more common after non-penetrating trauma. Injury to one or more arterial layers allow blood to force its way into the vessel layers along a dissection plane and create an intimal flap. The intimal flap may act as a nidus for embolic material and may cause occlusion of the arterial lumen. Most dissecting aneurysms result from spontaneous dissection, approximately 80%, much less from trauma. Most occur in the vertebral arteries. Overall mortality rate for dissecting aneurysm is much lower than traumatic intracranial aneurysms. Initial signs and symptoms of traumatic aneurysms usually related to the initial injury. The secondary presentation of traumatic aneurysm is related to the location and type of vascular injury. In peripheral aneurysms, usually rupture occurs within 3 weeks following the initial injury, with an average of 7 to 10 days. Usually associated with delayed neurological deterioration. Most common finding is an intracerebral hemorrhage, but also symptoms may consist of cerebral edema, stroke, usually ischemic. In the carotid and basilar vessels, epistaxis can be life-threatening, also can cause chemosis and cranial neuropathy. On clinical exam, sometimes a bruit can be detected. Cavernous carotid fistula is an example. Diagnosis of traumatic aneurysms requires a high degree of suspicion. Usually the head CT is the most common study obtained, with findings showing hemorrhage, stroke, or fractures. Angiography is the gold standard. In penetrating trauma, The traumatic aneurysms can develop early, even several hours following injury. However, most occur usually in the 2 to 3 week time period following the initial trauma. In general, first angiogram is recommended to be performed 10 days following the injury. If there is a high probability of traumatic aneurysm, angiography should be done at the time of admission. Trauma is the most common cause of subarachnoid hemorrhage. For diagnosis of underlying injury, CT scan is the first study. Traumatic aneurysm requires a high degree of suspicion, often associated with fractures. CT angiogram can be used as a screening tool. Cerebral angiography is the gold standard, with angiography recommended 7 to 14 days following the trauma. Treatment of patient is dependent on the location and type of vascular injury and clinical symptoms. Emergent surgery is indicated in the presence of a significant hematoma or mass effect, with treatment of the vascular injury if present at the time of surgery. Options include surgical exclusion of the aneurysm or endovascular techniques. For surgery, there is direct surgical excision if distal, as well as vessel bypass if proximal. Endovascular techniques are becoming more common, including coils and stenting. Conclusion: traumatic intracranial aneurysms are rare but important surgical problem in patients with penetrating intracranial trauma. Traumatic vascular injury should be suspected in all cases of penetrating injury. Angiography is the gold standard necessary to make the diagnosis, and digital subtraction angiography should be repeated if the first angiogram is negative, because delayed vascular injuries can develop in a delayed manner, even up to 20 days following the initial injury. Treatment includes both possible surgical treatment and/or endovascular treatment. Pipeline embolization and stents are important aspects in some traumatic vascular injuries. Endovascular techniques are continuing to evolve rapidly and offer versatility and safety alternative to open surgery for the treatment of traumatic intracranial aneurysms.